Parkinson's disease is a chronic, progressive disease. It causes degeneration of the dopamine-producing neurons in the brain, which leads to elevated acetylcholine levels. Acetylcholine and dopamine are supposed to be balanced in the brain. When you don't have adequate dopamine, the acetylcholine levels are too high. Symptoms occur when about 80% of the dopamine stored in the basal ganglia is depleted. As long as there are functioning nerve terminals that can take up dopamine, symptoms can be partially controlled. Now, Table 14.1 has a nice description, a concise description of the symptoms of Parkinson's disease. So, I'm going to just very briefly, we've got bradykinesia, which is slow movements, rigidity, that's cogwheeling. It's hard, it's rigid, and the movements kind of look like cogwheeling rather than that nice smooth movement. Tremors are pill rolling. It's like the thumb and the first couple fingers rubbed together, like you're rubbing a pill between your fingers. Postural instability. What does that mean? That means you don't walk real well. You fall easily. Dyskinesia. Difficulty performing voluntary movements. Well, it may be nice and smooth to just breathe, but when you want to get up and walk around, you have difficulty with it. Chorea, which is involuntary spasmodic movements of the limbs and the face. And dystonia, abnormal muscle tone. That's where you get, with Parkinson's disease, you get a shuffling gait. That's the dyskinesia, and that's the bradykinesia, and then that's the dystonia. And you also get kind of a flat, staring look. And that, again, is a combination of all these muscle issues that are getting together. Parkinson's is a progressive condition, but there's also rapid swings in response to the levodopa, which is the drug that is usually used first, and it's called an on-off phenomenon, where the Parkinson's will get worse because there's too little dopamine, and then we've got too much present, so we have dyskinesia. So it's not, the drug treatment doesn't provide a nice, smooth, stable situation. It tends to fluctuate. Levodopa crosses the blood-brain barrier. Dopamine doesn't, but levodopa does, and once inside the brain, it converts to dopamine, where it can be used to help with all the symptoms. However, levodopa alone also converts to dopamine in the body, which causes a lot of side effects, such as cardiac dysrhythmias, hypotension, chorea, muscle cramps, GI distress, and confusion. Now, levodopa-carbidopa is a combination drug, and the carbidopa within it helps prevent the conversion of the dopamine in the periphery, in the body itself. So there are less side effects, and there's less of that on-off phenomenon going on. The levodopa portion crosses the blood-brain barrier to do its job inside the body. The carbidopa does not cross the blood-brain barrier and prevents the levodopa from converting into dopamine into the body itself. As Parkinson's disease progresses, it becomes more and more difficult to control it with a levodopa. Ultimately, levodopa will no longer control the Parkinson's, and the patient is seriously debilitated. This generally occurs between 5 and 10 years after the start of the levodopa therapy, and there are other drugs out there to use to attempt to control the disease itself. Now, I had put on one of the earlier slides a picture of Muhammad Ali and Michael J. Fox. They both have Parkinson's disease, and they are both out there speaking out, saying we need more drugs, we need more research, we need to find out more about what's going on with this disease and how to treat it. All right, the nursing implications. Now, when starting the dopaminergic drugs, we need to be especially careful in helping people to walk. Now, the disease itself makes it difficult to walk, but when they start taking a dopamine family drug, it makes them dizzy, so they're at an increased risk of falling. Oral doses should be given to minimize GI upset. And we're going to encourage them to force fluids to at least 2,000 milliliters a day. That's 2 liters. Now, unless it's contraindicated. Why would it be contraindicated? Somebody's got a heart condition, can't handle the extra fluid. So we need to look carefully into that. We had talked about vitamin B6, pyridoxine, in the treatment of peripheral neuropathy. Well, in the case of Parkinson's disease, we don't want them to be using too much pyridoxine because it can reduce the effects of levodopa. So we're teaching them to avoid foods high in B6. Patients should be told not to discontinue their medication suddenly, because it will have a very unpleasant effect, a return of symptoms. And they should be taught what to expect about therapeutic effects and adverse effects that come from their drugs. The levodopa preparations can darken their urine and their sweat. And I had spoken earlier about the levodopa, the dopamine products eventually not working. It is not unusual for us to talk about drug holidays with them. No, they don't stop the drugs suddenly unless they're in a controlled situation when we're around to help them. But we may have a period of time when we say, okay, let's stop this particular drug for a while, let it flush out of your system, and then start it up again. As with all drugs, we monitor to the response to the drug therapy. And if it's working, we should see an improved sense of well-being, an improved mental status, an increased appetite, an increased ability to perform ADLs, and to concentrate and think clearly. We should see less intense symptoms, such as we should see fewer tremors, their gait is better, it's less shuffling, we're seeing less muscle rigidity and involuntary movements.